This is the overview of the 2011 PCRI conference. And one of the key things to understand about them is that they really want and are focused on helping men know their options.
Is it working for you?
Well, we'll find out. There we go.
Okay.
We'll go this way. There we go. No, just do it once. There we are. So today's program is a long one. And we're only going to talk towards about half of the information that was presented at the conference. I think it's going to take us about an hour and a half. Stick with us. There's content in here for the newly diagnosed. There's content in here for the survivor, and there's content in here for the warriors. We don't have specifically content directed towards the wives and ladies associated with men with prostate cancer, but there was some presentation material and I believe some workshop type sessions that also dealt with that as well. So this is a star cast of practitioners from Canada and the United States. And within the presentation, you will see a little bit written up about them, but I'm only going to land very lightly on them. This entire presentation will be presented on the web so that you will be able to read more of each of these gentlemen's specialties. And there eventually will be a DVD that will provide the entire presentations of the workshop available through the library. So we're just hitting the highlights of basically 2 days, and we'll do that in an hour and a half. So here goes. So this Prostate Cancer Research Institute, it was founded by Mark Schultz and Stephen Strum, two leading prostate cancer specialists in the U.S. And what they really wanted was an organization that would bring together leading edge in what they called insightful clinical research in combination with high-level education activities. And their mission is to improve the quality of men's lives. The outcome that they're looking for is really a patient who understands his disease and his treatment options, is empowered to communicate more effectively with his physicians, and coming out of that will achieve a better outcome. This is all about empowerment of the patient, and this is being delivered by leading oncologists that have not only a clinical research level of expertise behind them, but a real strong drive in education associated with prostate cancer. This is a new feature of the PCRI programming, and what it's trying to say here is, what's your shade? And they're developing a theme around different grades of cancer and have associated different colors with it. And that's helpful in that some of the treatment modalities that would be considered for a low-risk prostate cancer patient would be quite different to those that would be appropriate for an advanced cancer patient. And online, they will have a forum set up in each of these areas that you'll be able to participate even from here in Canada. So that's really quite a significant advance in some of their efforts to be supporting the educational needs of prostate cancer patients. So if we go to picking up this theme of 5 shades of prostate cancer, we have the low risk, the intermediate risk, high risk, and these forums will basically deal with people that have had no previous local therapy, meaning therapy directed towards the prostate itself. There will be a forum that deals with PSA relapse. And yes, these folks have had previous local therapy. And the advanced group will either have had local therapy, that's plus previous local therapy, or will not have had previous local therapy. So that's how they've clustered the way that they want to categorize people, categorize information, and categorize the messaging and the likes. A lot of research is also directed quite specifically towards the low risk and quite specific Lawrence Klotz. He started work in 1969 to describe an approach to treatments, and the first data began to come into the public literature in about 2002. This is a technique that recognizes the fact that indeed there is a lot of PSA screening that takes place today, and more. And it recognizes the flaw of PSA screening, which actually was attempted to be addressed by what Jason was mentioning beforehand. And that is where PSA screening is picking up a lot of people who have cancer, but it's a type of cancer that they will likely not die from. They'll just learn to live with that cancer. It's an indolent kind of cancer, and what they need is a method to be able to identify that group of patients versus those that have more severe types of cancer that is detected early. So this is a focus on early detected cancer with an attempt to try to pick up the really truly low risk, and for those that are not low risk, identify them at a point in time when a curative therapy could be introduced. There's now been at least 6 active surveillance studies published by Klotz and by other research groups. So this Dr. Klotz is not standing alone with the implementation of active surveillance as a prime mode of treatment for the early detected cancer patient. All of the approach of active surveillance relies on PSA kinetics. They rely on rebiopsy on certain kinds of findings, and the data set that he was speaking to back relative to 2009 was over 2,100 people. And we're talking about a cancer-specific survival within that group after 10 years of 97%. And the data will just continue to grow over time. So basically the eligibility for patients under active surveillance is that they have a Gleason score of 6 or less, that they have a PSA of 10 or less, that they have a clinical stage of T1C, T2A, and depending on age and other comorbidity factors, there's consideration of those, as well as less than 3 cores, in other words, 1 or 2 cores, or 0, and less than 50% of cancer identified in each core. So it's a pretty narrowly defined, very early stage cancer that certainly I didn't fit into. The follow-up schedule is not just sitting there waiting for something to happen. It's an active, very active program of PSA and DRE testing every 3 months for 2 years, and then every 6 months, assuming the PSA is stable. After the first year, a 10 to 12 core biopsy, and then biopsies every 3 years until the age of 80. And there's optional transrectal ultrasound on alternate visits to the doctor. And there's quite specific triggers for intervention. And so if he sees doubling times of the PSA where they are less than 3 years, that would be a trigger for intervening in some way, and he's saying let's have at least 8 determinations to figure out this doubling time. And he's saying that about 20% of patients fall into that particular category. If there is grade progression on rebiopsy from a 6 to a 7, 4,3 or higher, and that's covering 5% of patients, or if there's a new nodule. Now in that draft recommendation that came from this particular group in the United States, they were talking about 75% of PSA tests that really don't relate to anything. Well, this sort of corroborates that, but in a different way. 20% of his patients are, or 25% of his patients will be upgraded as soon as he's got a sense that this thing is a more aggressive cancer. Now, for those of you that have interest in reading his most current publication in the area, it's 2010, and it's actually quite a readable article. So if you happen to be a candidate for active surveillance, I certainly would encourage you to have a look at this particular article. Here's how he closes the previous article that I mentioned, that it's active surveillance is an appealing option for men with favorable risk, particularly those whose extent of disease appears to be minimal. It's demonstrated to be safe in the intermediate time frame, and the quality of life benefits are indisputable. And these physicians, they use the word controversy. Controversy is where there's not agreement. And the controversy in the active surveillance field relates to optimal patient selection and ideal triggers for the intervention.
Stewart, do you know if we have in Calgary an active surveillance group?
Well, there was the suggestion that there be within this organization a group parallel to Warriors that would be a group that would talk to issues related to their experience on active surveillance. And that's something that we as an organization should maybe give some credence to. And the talk of it, I think, was Ron, you suggested at the last meeting, actually.
But there is no urologist or in the city spearheading this, or
I'm not aware of. I'm not aware of it being a very specific practice of any one urologist. I'm sure that they're all aware of it now.
I find that I play a role in making my urologist more aware of it. So I think if we get such a group started, maybe we can do some educating of the professionals.
And this is the purpose again of the PCRI, is to educate the patient as well as the urologists that are in the field, that aren't necessarily close to the latest in the research associated with prostate cancer. Okay, Gary, sorry.
Sure. So how is that? Can you hear me? A little closer? Okay. Okay, as shown on the introductory slide, I'll be providing an overview of 4 lectures that were presented at PCRI. And in the first one, we're dealing with one doctor's approach to what is called second-line prostate cancer treatment after first-line treatment fails. And then we'll deal with high-intensity ultrasound as a treatment, followed by radiation as a treatment, and then by surgery as a treatment. So first, a few remarks from a personal point of view. I'm not medically trained, neither is Stewart for that matter, but we're both prostate cancer survivors and a patient, like many of those in the audience. So I can offer a patient's point of view of what I observed at PCRI 2011. And as Stewart says, copies of the full conference videos and slides based on past years are really quite amazing. And there's far more information there than you could ever possibly internalize. But those will be available for borrowing from PCCN probably in mid-November. You know, the January meeting. One general observation I have is that since each of the original presenters at PCRI is an expert in his particular field, I perceived that there was quite a bit of bias in each presentation, which tended to favor their particular specialty. No surprise there, I guess. In fact, when the presenters make comparisons between treatment options, the other treatment options besides the one that they are expert in, some of the competing options seem to be understated or left out entirely. And I don't know whether that's by choice or not, but it happens. And so consequently, you may notice that some of the claims made for a particular treatment as being superior by that presenter are matched by another presenter's equally rosy claims. All the more reason, therefore, to carefully look at the videos once they're available to you to better understand the difference between the claims. And finally, and I guess this goes without saying, that your own medical provider is the best person to explain what the differences really mean and if the treatments apply to your circumstances. So this particular presentation is called After Lupron, and it was deals with second-line treatment, which the presenter, Dr. Myers, applies once prostate cancer has recurred after failure with Lupron, a common first-line prostate cancer treatment. Dr. Myers has a nickname, Snuffy. He's a medical oncologist who is in private practice in Virginia. He is widely published and is recognized as one of the world's foremost experts in the treatment of prostate cancer. Most of the people in the Warriors group are intimately familiar with his newsletters because he makes them very personal, gives lots of cases, so it's very easy for you to look at a case that's most closely parallels your own circumstance and see what the differences are between the treatment he's offering them and what you're being offered. One of the big points that Dr. Myers makes is that whatever is heart healthy is also prostate cancer healthy. And unfortunately, regardless of the kind of hormonal treatment that you have, extended use of androgen deprivation therapy, as it's called, or ADT, especially Lupron, commonly increases the risk for heart disease and the likelihood of what is called metabolic syndrome, which is a precursor to diabetes and obesity. It's a real challenge if you're on one of these ADT drugs to keep your weight in trim. It's difficult. So he says that exercise and diet both can lessen the risks of succumbing to metastatic prostate cancer, and you can also improve your quality of life while under treatment if you engage in appropriate diet and exercise regimen. To counteract the negative effects of ADT, he specifically recommends the Mediterranean diet as an anti-prostate cancer diet. This is the diet that's commonly expressed by peoples that live in Italy, maybe the North Tier African countries, certainly Italy, Greece, Spain, so on. And with respect to exercise, interestingly, he recommends both aerobic exercise and weight training to mitigate the development of recurrent prostate cancer. It's been very well proven that if you have prostate cancer, one of the best things you can do for yourself is to exercise regularly. It seems to support the immune function. And in fact, he suggests that prostate cancer sufferers should exercise aerobically a minimum of 30 minutes per day, and that you should weight lift 3 times per week. This slide illustrates that prostate cancer is a disease which, if it escapes the prostate gland, frequently spreads first to the seminal vesicles and then to the lymph nodes. After that, metastasis to the bones usually occurs. And he is the first one that I have ever heard talk about this concept, which is called oligometastatic disease. He contends that after failure of first-line treatment, all is not lost. If there's only a limited spread outside the prostate gland to the lymph nodes, and there are less than 5 bone lesions, then in many cases, this is what he refers to as oligometastatic disease. And this is, in other words, a transitional state between localized disease and widespread systemic disease, where it's very difficult to control. He believes that the reason for this is because these initial metastases to the lymph nodes and the bones are primary sites of origin for further metastases, and that early detection and aggressive treatment at this point can arrest further metastasis. And he's been extremely successful at doing that. He also points out that there are amazing advances in cancer imaging that have occurred in the last few years, which Stewart will talk about in one of the later presentations. And these advances allow many men who fail first-line treatment to have a second chance at cure, curiously, with targeted radiation. In particular, imaging specialists that Dr. Myers works with have had excellent success in identifying, first, cancerous lymph nodes using an MRI scan with a high-contrast agent called ferromoxetol. And second, identifying bone lesions using a PET scan with F18 sodium fluoride as the circulating fluid, which, by the way, is unusually sensitive to bone lesions. This is then followed by radiation treatment and by his second-line drug treatment. So once he's gotten through that sensing and radiation exercise, he then begins second-line drug treatment with ketoconazole. This drug is dramatically more effective when the PSA is less than 10 and the number of metastases is small. And if, on the other hand, there is extensive progression of the disease, then the response to keto is poor. Interestingly, he also uses the female hormone, estrogen. Estrogenic compounds are sometimes used as second-line prostate cancer treatment by him, especially when androgen blockade by drugs such as Lupron are no longer effective. And he's found that estrogen kills prostate cancer 2 ways. First of all, it decreases testosterone, and also it triggers a death pathway that's independent of testosterone. This is not for everybody, but when he uses it, he typically uses estrogen skin patches rather than oral estrogenic drugs who have a bad reputation and poor side effects. He also uses another drug as part of his combination drug therapy called leucine, because it stimulates the body's immune system and suppresses prostate cancer. This is not the only drug that operates in this way, but it's the one that he tends to use. This is an extremely expensive drug, however, and does have some negative side effects. In fact, I've never heard of anybody in our Warriors group that has ever had experience with leucine. The key to his treatments are that he uses leucine in combination with ketoconazole to improve the response rate of ketoconazole. And it will improve that ketoconazole anti-cancer effect by as much as 75%. And then further, by adding an estrogenic compound called estradiol, he's found that you can further improve the effectiveness of keto and leucine. And this reduces the keto fatigue, which invariably happens. Eventually, the body doesn't react to keto anymore. And also, by adding the estradiol, you can reverse the bone loss. And you can also speed the healing of bone as the bone metastases die off. Estradiol is one of the few natural hormones that has been found to actually grow bone. If the cancer has progressed beyond second-line treatment, chemo is usually the next treatment step, and adding leucine to chemo, which is usually Taxotere, that's the name of the drug, increases the response rate by 40 to 50%. So he's found these amazing results by using his combination therapy. A 73% reduction in PSA in 78% of cases, 49% of patients reaching an undetectable PSA, and 84% prostate cancer specific survival rate was achieved. A lot of times you'll hear people talk about survival, and it's important to separate death from all causes from death that is specific to prostate cancer. So that's what he's claiming here. He claims that his combination drug therapy technique is the best survival rate ever reported for any second-line hormonal therapy. And he hypothesizes, this has not been proven, that the effectiveness of his particular treatment protocol occurs because of an improvement in the immune system resistance. So this slide is a bit difficult to see, but it shows two graphs. The first one relates to what happens when you're on chemotherapy, and the second relates to what happens when you're on Dr. Meyer's second-line drug therapy. He specifically indicates that on the first graph, the Taxotere only has a 20 to 30% survival rate after 33 months, whereas the hormonal treatment that he recommends typically has an 80% survival rate. So the difference is dramatic. And finally, he is extremely excited about a new protocol called molecular profiling, which is also known as gene therapy. He claims that this has now arrived as a practical cancer-fighting tool. It's being used for prostate cancer. This approach profiles the prostate cancer extracted either from a biopsy or from the circulating blood at the gene level to determine the sensitivity of the patient's own cancer to specific cancer biomarkers. And these in turn point to specific drugs that might not otherwise have been considered. This process is especially applicable to advanced cancer patients. And one U.S. firm that has pioneered molecular profiling is called Caris Target Now. So the next presentation relates to a protocol called high-intensity focused ultrasound, which is called HIFU for short. And this deals with the experience of Dr. Gange in using Sonoblat HIFU equipment, a technology which has ultrasound waves, which uses ultrasound waves for the destruction of prostate cancer tumors in the prostate gland by heat. It basically vibrates the molecules together and they are destroyed by ablation, and therefore the name. So Dr. Gange is a graduate from UCLA and the University of Kentucky. In early 2009, he was a co-founder of a private HIFU clinic in Salt Lake City, Utah, and he became one of the first urologists in his area of the United States to perform HIFU surgeries for prostate cancer. Now, interestingly, with respect to HIFU, it's not well known, and it's licensed for use in several countries worldwide, including Canada and Mexico, where it has achieved good success as a primary prostate cancer treatment for low-risk prostate cancer. But interestingly, it's not licensed for use in the United States, where it's currently undergoing long-term FDA-mandated clinical trials. Consequently, American oncologists trained in HIFU offer out-of-country prostate cancer treatment at centers in Mexico and the Caribbean. I have discovered that HIFU is offered for prostate cancer treatment in 5 private clinics in Eastern Canada. And as I understand it, HIFU technology is approved by Health Canada for prostate cancer treatment, but it's not currently covered by any provincial health authority. So, if you want to have a HIFU treatment, you apparently have to pay somewhere between $20,000 and $25,000 out of pocket to be treated at one of the Canadian private clinics. Now, I have to say that HIFU for prostate cancer treatment is controversial among some Canadian healthcare professionals, as evidenced by a number of articles that are published in the Canadian Urological Association Journal. So there's a lot of pros and cons. Nevertheless, Dr. Gange touts HIFU as a minimally invasive therapy for prostate cancer, and this is for 3 reasons. First, it's a highly precise, targeted procedure. It can be performed on an outpatient basis, and there are fewer complications than there are with other prostate cancer therapies. So MRI is used both pre-HIFU to delineate the tumor and post-HIFU to verify the treatment success. So this slide shows 2 competing technologies. The Sonoblat, which is the subject of his lecture, is on the left, and the Ablatherm is the technology that's shown on the right. And if you look carefully, you can see a patient laying on his side undergoing treatment. So it's very compact. The Sonoblat equipment is unique relative to its competition in that it offers both ultrasound image guidance and ultrasound ablation from a single probe. So the key features of this equipment are its compactness. It features, interestingly, a rectal chiller, which circulates chilled water to protect adjacent healthy tissues from heat damage. It offers 3D imaging, and it offers 3D Doppler technology, which locates and avoids adjacent nerves. And it has a very tiny, a 3 millimeter focal zone for high precision. This slide shows that Sonoblat, it shows the focus on the left-hand view, and then it also shows that there are a number of shots that are required to ablate a typical 10 to 12 millimeter lesion. You can see the 3 millimeter focal zone, and you can see the size of the tumor that it's attempting to eradicate. So it has to make several shots to ablate that tumor. This slide shows that Sonoblat compares very favorably with other first-line treatments with respect to incontinence, impotence, time to catheter removal, extended biological disease-free status, or BDFS, and a lower rate of prostate cancer recurrence. And HIFU is also an appropriate second-line treatment after cancer recurrence following any one of the first-line treatments. So it's maybe a bit difficult to see on this slide, but incontinence is low, impotence is probably as good as or better than radical prostatectomy, radiation external or radiation internal. And the catheter removal statistic is better than almost anything else, and it has very, very good biological free period relative to the other technologies. Who qualifies for HIFU? First of all, it's really only suitable for localized prostate cancer with a prostate volume less than 40 cubic centimeters and no bigger than 40 millimeters in extent. So a healthy young man of age 20 typically has a prostate volume of 20 cubic centimeters. So it gives you a rough idea. And also, it's, as I mentioned earlier, it's also suitable for recurrent localized prostate cancer. And finally, the unofficial motto of Western HIFU is shown here on this slide. And for the rest of us, this slide could be named I Wish. So the next presentation is about prostate radiation technology.
When you said that the cost is $25,000
Yes.
for the operation, so how many did all this information on how many surgery has been done? That we come with all this information and it's not done in Canada because they have to pay $25,000 and not in the States because not approved. So it's in Mexico or where? So
Well,
how
it's
many patients?
It's available. I don't know the answer to that
So
question.
all this information and we don't know how many patients.
Well, I think there is a lot of information available online on the internet. For example, it's a very...
Where are the people that is not in Canada, not in the States? So where did they come
Well,
from?
the thing is, if you're a Canadian and you have to pay $25,000 out of pocket, you may be very reluctant to spend that money, especially when there's lots of other treatment options available.
So how many that they come with all this information and the comparison?
Gary,
Well, it looks
HIFU came from Europe. HIFU has been in Europe and successfully used for probably 10 or 15 years. This equipment didn't just come from nowhere. It's European equipment.
It's also very commonly used in Japan. And these centers that the American oncologists use out of country in Mexico and in the Caribbean are very popular. And so are Canadian centers for Americans who simply walk across the border and have it done. But how many? I don't know. Don't know the answer to that. So moving along here, this presentation is about prostate radiation therapy. It's very techy, and it describes current and newly developing radiation technologies, and it compares outcomes with each other as well as against other non-radiation first-line treatment options. The presenter is Dr. David Demanis, who is qualified as both a medical and a radiation oncologist. He's currently the director of brachytherapy at the UCLA School of Medicine. He specializes in brachytherapy and amazingly has performed more than 10,000 surgical implants using the current technology as well as the newer form called high dose rate brachytherapy, which is abbreviated HDR brachy. This slide shows a broad categorization of radiation therapy. The first track, external beam radiation. So the external beam track shows that there are three main external beam radiation technologies. The first is 3D conformal RT, which is abbreviated 3D RT. And then there's intensity modulated RT, abbreviated IMRT. 3DRT is the conventional form of EBRT. It typically employs a CT scan to identify the three-dimensional shape and position of the prostate gland and seminal vesicles. Radiation doses are typically 70 to 75 gray, and they result in a longer time to biochemical failure and lower mortality rates than earlier forms of EBRT. IMRT is newer than 3DRT, and it uses a similar pretreatment approach. The IMRT approach, however, uses multiple radiation beamlets, individual beam modulation, and a computer-generated plan. So it's highly customized for an individual's prostate problem. And this is all for the purpose of more precisely shaping and delivering the radiation field to the prostate and its margins. Radiation doses are typically up to 81 gray. And finally, there is a newer type of radiation protocol called stereotactic body RT, abbreviated SBRT, which combines IMRT with online image guiding. And in this technique, marker seeds are implanted into the prostate beforehand, and real-time imaging is used during each session to further improve the delivery accuracy. So this offers even more dose control than IMRT, and also shows the delivery of, allows the delivery of radiation to the pelvic lymph nodes. So this means that SBRT is a safe and effective treatment for both local and regional prostate cancer. The brachytherapy line, on the other hand, brachytherapy is both a generic term and a specific term, but it typically means, in its standard form, the insertion of permanent radioactive seeds. And it permits an escalation in dose compared to IMRT, in other words, up to 100 gray, which is quite a lot. Brachy has proven to be an effective approach, especially for low risk and some intermediate risk prostate cancers. And then there is a newer type of brachy, which is called high dose rate brachy, which uses a computerized robotic delivery system to insert temporary radioactive wire implants into the prostate target area, the surrounding tissues, and also into the seminal vesicles as appropriate. And these are then withdrawn within several hours after initial placement, so there is no residual radiation that can affect other nearby healthy tissue. HDR brachy is more effective than the standard brachy for treating prostate cancer within the prostate gland, and can even treat prostate cancer at the prostate gland margins, as I mentioned earlier. And later, if the cancer reoccurs, the procedure can safely be repeated. So commonly today in the United States, HDR brachy and IMRT are used together for high-risk prostate cancer. So this slide is a tabulation that shows the effect of increasing the radiation dose on prostate cancer control when using 3DRT, the standard form. Higher doses are possible than with the earlier EBRT method, but this results in higher gastrointestinal toxicity at these higher doses. So you can see that the clinical control is 93% for 78 gray versus 82% control for 70 gray, and that the gastrointestinal, the G2 grade or the G3 grade, are much higher than they are for the lower doses. The shaped target dose of IMRT shown in this slide offers higher target doses in other words, from 75 to 81 gray. It therefore has less stray radiation dose to nearby healthy tissue and much less gastrointestinal bleeding. So the comparison between 3D conformal or 3DRT is 25%, and with IMRT only 5 to 6%. This slide shows the use of a transrectal ultrasound probe, which is called a truss probe, both for locating the prostate cancer tumors and for positioning the insertion device for permanent brachyradiation seeds. The result is highly targeted radiation and better gastrointestinal bleeding performance compared to IMRT, as I mentioned in the previous slide. And truss is also used for biopsy sampling. So the picture at the upper right shows the probe, and it also shows the template through which the wire with the right radiation ends are inserted into the prostate. And the slide on the right-hand side shows a closer view of that template. The slide in the lower right shows the placement of permanent seeds. And this view shows a pictorial view of a prostate that's filled with seeds. This slide shows the results of what's called a meta-analysis, in other words, a scatter chart comparing several first-line prostate cancer treatments for low-risk patients, and it plots the percent of patients who are disease progression-free on the vertical axis versus the time since treatment on the horizontal axis. So each symbol represents a particular study, and the legend on the right-hand side indicates what particular modality was used. And this scatter plot analysis has lumped all of the brachy treatments, as shown by the blue oval, and all of the surgery treatments, as represented by the red oval, versus all the EBRT radiation studies, as evidenced by the green oval. So you can see that just taking a long view of all of this, that there is a much higher disease-free progression that's possible with brachy relative to these other two modalities. And I guess the other point is that there are slides that also show the impact for a patient with intermediate risk and a patient with high risk, and you see the same pattern. However, the brachy shows up even better for intermediate and for high risk than it does for low. So this slide depicts that there are two treatment options for HDR brachy. There is what is called HDR monotherapy, or HDR alone, which is used for treating the prostate gland plus the prostate gland margins. And then there's an alternate two-treatment protocol which uses HDR brachy for the prostate and margins, with IMRT added for any infected lymph nodes. This slide shows Dr. Demanis' treatment experience with low-risk, intermediate, and high-risk patients for the HDR plus EBRT combination. Once again, it plots prostate cancer-specific survival versus time since the treatment is graphed. And the results are excellent, showing that low-risk patients achieve 92% progression-free circumstance after 10 years, 120 months. Intermediate, 87%, and high-risk patients, 63%. Not too shabby either. the two tabulations in this slide show the remarkably low side effects of HDR brachy monotherapy. First, the residual gastrointestinal side effects, and secondly, the genitourinary side effects. So with respect to the first, gastrointestinal, there is very little grade 2 gastrointestinal side effects and no grade 3 side effects. And for genitourinary, the rates are higher, but they're still quite low. And finally, this slide shows Dr. Demanis' summary on the comparison between surgery and radiation. He concludes that for early treatment, both surgery and radiation have good tumor control rates, although the side effects are different. And for advanced cancer or high-risk cancer, that radiation offers the advantage of being able to treat a wider margin as well as the lymph nodes. And finally, that radiation is a better treatment for older patients or those with other medical illnesses. I think I got the hang of this now. This final presentation is titled Surgical Options for Prostate Cancer. It's also fairly techy, and it describes and compares outcomes for the various surgical options versus other non-surgical first-line treatment options. The presenter was Dr. Timothy Wilson, who's an expert in performing open laparoscopic and robotic-assisted laparoscopic surgery, which is known by the short form of robotic RP, or robotic surgery. He's one of the top 6 surgeons worldwide using the robotic approach. He's director of the prostate cancer program at the City of Hope Cancer Center in Los Angeles, which is one of the largest oncology centers in the United States. So this is an overview of all of the first-line treatments that are available. There's a little bit of overlap on this slide relative to the previous presentation, but nevertheless, it shows all the radiation options again, which are external beam radiation, and the two principal kinds are 3D conformal RT and intensity modulated RT. And then there is internal radiation or brachytherapy with or without EBRT. And then finally there's high dose rate brachy. You also have other non-surgical treatment options like hormonal therapy and cryosurgery, which is not really, there's no physical surgery involved in cryosurgery. And you also have high-intensity focal ultrasound, HIFU. The other treatments shown on the slide are non-surgical. They're labeled as experimental. But they are typically second-line treatments, not first-line treatments.
Excuse me, with all these several methods of treatment, is there a difference in the side effect on the impotency?
Yeah,
is
there's
one better than the other one? That some people say, yeah, they had their erection kept and the other no.
Absolutely.
Which one of these that you say, the cryo or the brachy, or which one? Or they are all the same?
Well, they're not all the same.
So what's the difference?
As we proceed through this particular presentation, you'll see what this particular presenter claims for his approach. And so, if we deal with the surgical options, the radical prostatectomy. Radical, by the way, means extensive or major. So there are 3 types that are shown here. There is the most common type, which is called a radical retropubic prostatectomy, abbreviated RRP. This is where they make an incision in the lower abdomen and go behind the pubic bone. And then there is another type called perineal open surgery, or RPP, which is only performed occasionally. And then finally, there is the computer-assisted laparoscopic surgery, which is called robotic prostatectomy. And in this particular procedure, the surgery is performed by the surgeon with a computer-assisted device, not a robot. This graph shows a representative breakdown of about 10 years ago of the primary treatments for prostate cancer. The most frequent treatments performed were surgery, 43%, radiation, 25%, and hormonal treatment, 12%. This slide is also somewhat dated and difficult to see the details, but it compares prostate cancer specific survival over a time span of 5 years for low risk, intermediate risk, and high risk patients. And to be able to understand the chart, it's helpful to realize that surgery is in blue, radiation is dotted, brachy is in red, and brachy plus neoadjuvant hormonal treatment is in black. For what it's worth, neoadjuvant simply means before. So if you have brachy, sometimes in order to reduce the size of the prostate, they'll give you a course of hormonal treatment to shrink the prostate. But this shows that if we look at these results, that for the low-risk patients, there's a 90 to 95% survival after 5 years, and the best result is for brachy plus neoadjuvant hormonal therapy, but there's not a lot of difference between it and the other modalities. Surgery, radiation, and conventional brachy also perform fairly well. On the other hand, treatments for medium-risk patients show widely varying risks of mortality. So you can see 3 of them grouped together, and one of them is much worse than the other. So the 3 that are about equal, at about 60% survival, are brachy plus hormonal treatment, surgery, and radiation. And for high-risk patients, and this is the key point of this author, the surgical option is far superior to the other options. But it should be recognized that this is an old slide, and it doesn't compare the surgical options with HIFU or with the latest radiation option, HDR brachy. And this is a very interesting slide because it compares the major side effects of surgery, brachy, and radiation as what the author terms a health-related quality of life assessment by patients 2 years post-treatment. And what's really a shocker on this particular slide is that whereas it's hard to see here, but this is irritative, incontinent, bowel, and sexual. So every one of these modalities has an extremely low assessment of sexual satisfaction, only 30 to 40%. So that partially answers your question. And another thing that's not shown on this particular slide is the fact that the side effects are much worse during the early post-recovery period, and they tend to settle out after 1 to 2 years. So this slide summarizes the factors that favor surgery in the view of the presenter. Those that have intermediate or high-risk disease, those that have existing urinary or bowel problems, having a large prostate, having had a previous prostate surgery, or having had a history of bladder cancer. And another two key points to make about surgery is that surgery would normally be contraindicated if the cancer diagnosis indicated penetration outside the prostate. And also that reoccurrence after surgery is easy to treat with what is known as salvage therapy and has very few side effects. So this slide shows the 3-arm Da Vinci robotic radical prostatectomy machine with its 2 surgical arms and 1 viewing arm. 1, 2, 3. I don't know which one is which, but I think they're multifunctional. The key conclusions when you compare an open prostatectomy, which is RRP, that's the retropubic radical prostatectomy, compared to the Da Vinci prostatectomy, are that the operating time is roughly the same, and that in almost all other respects, the robotic approach beats the open approach hands down, with respect to the fact that it features no blood transfusions, fewer complications, shorter catheter time, lower resultant positive margins, and a shorter time to achieve continence, erections, and intercourse. And in the view of this author, robotic RP is the new gold standard for surgeries. So that's it for me.
And we have Dr. Dusing, who's the director of the Division of Nuclear Medicine with the University of Kansas Medical Center in Kansas City, Kansas. And he brings an interesting complement of skills together in oncology and radiology and molecular imaging. Let's hear what he has to say. The nub of his presentation is that in the US, there's 220,000 new cases of prostate cancer identified each year, of which 165,000 are treated with some of the potentially curable therapies that Gary made mention of. Keyword potentially. But 40% of those treatments experience a PSA recurrence. So we're talking about a lot of hard, fancy technology being focused on prostate cancer with hardware that's not giving solutions. And his presentation is focused on the needs of the 66,000. And more young men, healthier at the time of their PSA recurrence, are being identified. This comes about as a result of the PSA being made available, earlier treatments, perhaps with treatments of 10 years ago that are not as advanced as they are today. And so you've got just a very large number of PSA recurrences happening in the current year, 2010 it was, I guess. So the challenge as he identifies it is to localize just where the recurrence happens and at a very early stage. And then to effect a cure, if possible, rather than to relegate that patient to a palliative hormonal therapy of one sort or another. So the current workup that all of us have likely had here is that we've had our bone scan with a radionuclide bone scan, and many of us will have had a CT scan. And he's asking the question, really, is it cost effective and is it even reasonable in the context of the recurrent patient? He's identified a number of different other imaging modalities that are possible. There's been mention made of truss as a technique to help in biopsy guidance, mention of MRI by Gary. Prostate has been mentioned for several years amongst the Warriors, and has been talked about in previous years by us here at PCCN Calgary. Gordon made mention, I think, of a sugar-based molecule that has a radioactive fluorine on it that can be identified with positron emission tomography, i.e. PET. And the specialty of this particular author is this carbon-11 acetate PET, the C11 ACE PET. And that's what I'll spend more time talking about, because this is really new on the field and not widely available, but it's certainly under development. So the bone scan. The bone scan is really not of much use for PSAs less than 10. It's fairly insensitive for PSAs less than 20. For this cohort of 306 cancer patients with a PSA of less than 20, only one patient had a positive bone scan. So when your practitioner says you're less than 20 PSA and your bone scan's clean, well, yeah, it's just maybe that the bone scan isn't capable of picking up the cancer that you might have in the area. But it's a useful prognostic indicator for the advanced disease, because it is capable of picking up advanced disease, and the more sites that are identified, then likely the shorter predicted lifespan. If you want to know that, of course. The CT scan is interesting. It's really quite sensitive in picking up anatomic images. In other words, it can really get down to fine detail, as small as whatever the ossicles are of a mid-ear. So just believe it, it's small. But specificity is another question. And so you've got this lymph node that's 1 centimeter. Well, I've got several that are a little larger than 1 centimeter. The question is, are they prominent normal nodes? Is it a reactive node to an inflammation that you've just recently had along that lymphatic drainage system? Does that node contain metastatic cells? And is that indicative of recurrent prostate cancer? CT scan can't tell you anything. All it's telling you is you've got a lymph node of such and such a size. So a CT scan has got its very real limitations relative to recurrent prostate cancer. I think it's got limitations in identifying a lot of aspects of prostate cancer at all of the various risk categories. Prostate is interesting, and I only present it to illustrate to you what some of the tools are, if you're intrigued with the tools. PSMA is a protein that is released by a prostate cancer cell. And there can be antibodies that will recognize that particular protein. So this symbolizes an antibody that can recognize that particular protein that is released by the prostate cancer cell. It then is linked to an atom that can release gamma radiation. So the prostate, this particular compound is injected, and the antibody finds the PSMA that is being released by the cell, and the gamma camera then detects the indium 111. That's a pretty cool technique, but you're going to find more and more of this as a technique to try to, with other combinations, to try to more precisely identify where the prostate cancer is within the body. Something called PET plus CT will give both metabolic and molecular information as well as anatomic information. So this is a combination of the biology that's going on in the system as well as the structure. And that is overlaid, those are overlaid on each other, and is highly informative. Some cancers have increased metabolic needs for sugar, glucose. They're called glucose-avid cancers. Well, this particular scientist is working with the C11 acetate molecule. The C11 is a radioactive carbon, and the acetate recognizes the fact that the cancer cells have an appetite for the acetate molecule. So again, we've got these a way of identifying specifically cancer cells that are rapidly dividing. They need the acetate, and there's the corresponding detection hook, what happens to be the radioactive C11. So the benefit of this technology is that it gives very high spatial resolution with the PET-CT, with the thirst that the prostate cancer has for the acetate. And the C11 just is there as the indicator. It's a very safe molecule. The C11 acetate has been identified 20 years ago. It's used in cardiac imaging. There's a corresponding radioactive F18 choline. It's not approved. Real problem with the C11 acetate is that it's got a short half-life of only 20 minutes. So you've got to make this material right on site, because it's not going to be around for very long if you want to use it at all. There was a pilot study comparing the Prostate, or this indium compound that I referred to, with the acetate. He started out with 20 individuals, and his putative sensitivity with the C11 acetate was 85% versus 30% for the Prostate in 20 patients for early recurrence. So this is recurrence where the median PSA is 1.03. Very, very low PSA levels, and he's coming in and able to identify just where that cancer is. And the mean tumor size, 1 centimeter. I think in the case of something like CT, you almost need 2 centimeters or something to be able to have a good indication that you've got some cancer there. So he's saying that this acetate PET may be the best tool for detecting early prostate cancer recurrence and may be a future diagnostic standard. It's available at this particular site. I'm not aware that this imaging technology would be available at any other site at this point. So he's actually applied this in 250 cases, and he's applied it across a range of or post-operative, post-radiation, and hormone only. Let's have a look at one example. And the example would be a 63-year-old man, Gleason 7, happened to be a physician, and he underwent robotic prostatectomy with dissection of the nodes. Only problem was they couldn't adequately access the right side of the nodal system. So this gentleman's PSA had risen to 1.13 2 years after his initial robotic prostatectomy. So he underwent an external radiation therapy to the bed, and from a period of August 2009 to January 2010, well, he's up at 1.4. This isn't going very well for him. And February 2010, this is rapidly increasing. A 3 PSA unit increase in 1 month. This fellow's got to do something. And so he was given the acetate PET diagnostic imaging in February, and it showed 3 nodes in the right chain that could not be accessed in the very first robotic treatment. Well, the patient was subsequently treated with a stereotactic radiation precisely on those nodes in March 2010, and 3 months later he still had a PSA of less than 0.01. So really targeted imaging coupled with stereotactic treatment can work. So let's talk now about refractory disease and bone
How expensive?
I have no idea.
You have no idea.
I mean, it's experimental at this point.
Is there?
Only 250 patients in this guy's hands, but he's there. And he'll take new imaging clients. You've got to have a 1 PSA. It has to be rising.
Over 1.0?
1.0 and rising.
That's his only quality?
I believe so,
Roughly.
roughly.
What's the best imaging in Calgary?
Or you could get Prostate.
You can get Prostate here? Okay.
I've had Prostate.
Okay. So we have bone scan, CT scan, and Prostate. MRI. Yeah. So, Dr. Schultz. Dr. Schultz is the founder of this particular PCRI, but he's also a private head of the medical director of the Prostate Oncology Specialists, Inc. in California. And he's got various associations with the with various hospitals in the area. He's quite involved in research trials and quite highly published in the likes. His most recent book is called Invasion of the Prostate Snatchers. No more unnecessary biopsies, radical treatment, or loss of potency. Might be an interesting book to read. So, a lot of joking going on amongst the professionals at the meeting about this book of his, Invasion of the Prostate Snatchers. The surgery fellow, he sort of took it as fair play. At least I didn't hear him howling. Remember, we go back to the original blue shades, 1, 2, and 3, low, medium, high risk, and the various kinds of treatments there. I'm not going to deal with these. He doesn't deal with these in this particular presentation. What he deals with is PSA relapse. This is an interesting slide comparing the life expectancy after relapse for various types of cancer, and prostate cancer is well over 12 years. Life expectancy after relapse compared to 4 months for pancreatic cancer. So the treatments on relapse are observation, sort of similar to this active surveillance. If the PSA doubling is slow, you just sort of continue to watch it. The tools are IMRT to the prostate bed, the nodes are both. Some of the other tools are the various types of hormone blockage, use of angiogenesis blockers, thalidomide, Avastin, and immune, or combinations of these. And that's what Dr. Snuffy-Myers is talking about, is using combinations of these in a relapse condition. And he's getting, in the case of Snuffy-Myers, quite good results, as you saw earlier. Well, let me just continue here. For the advanced disease, shade 5, there's not as many possibilities here. At least Taxotere was brought onto the market as the first drug to result in any net increase in survival. And that was about 2004. That was the first drug that provided any hint of survival. We'll spend a little time on combinations, and Jetvana is a new drug that is a country cousin of Taxotere, showing some survival benefits over Taxotere, but also showing some increased toxicity. The exciting area, I think, is in these Taxotere combinations. So, first combination to have a look at is this Taxotere plus Custirsen. And Custirsen is a drug that has been developed out of the University of British Columbia and is being combined with Taxotere. This gentleman is a pretty happy camper because on January 1, in January of 2011, he was coming in with a PSA of 100, and by August of this year, his PSA was down to 6.5 in a combination treatment. I think there's an earlier slide that I need to focus on first of all. It's this one. Taxotere alone, only 45% of men have more than a 50% decrease in their PSA. Taxotere is ineffective for half of the men that are put under treatment. When you have this Custirsen combination, you see the increase in PSA decline. You see an increase in survival. We're now not talking about 3 months. We're talking about almost 8 months, and an increased survival of 41%. So that's really making Taxotere stand out much more effectively than it was when it was originally approved. Let's have a look at a three-way combination that includes thalidomide. Well, for heaven's sakes, we all know about the nasty things associated with thalidomide in young children, and in the fetus, I should say, in the young children. The same biological processes that were affecting the fetus actually are operable in this particular case for ourselves as adult men and the likes, and it's beneficial. In this three-way, this is a stunning waterfall graph, is what it's called. And only 2 men failed to show a decline in their PSA out of 60 men. 90% of men had greater than 50% decline. And if you look down here, the percentage of decline, say at 80% or more, that's probably 75%. So this three-way combination is really quite effective. So his summary point is there are effective Taxotere combinations. Taxotere plus carboplatin, Taxotere plus Zoelida, Taxotere plus Avastin with thalidomide, Taxotere plus Kersterson. That's an amazing number of combinations just there. And life gets pretty complicated for your oncologists as well as for patients trying to figure out, well, what am I going to do? Which is the better? And it's going to be really complicated for policymakers within the healthcare system to figure out, well, which of these are effective and least cost. So the general principles for selecting treatment: you have to balance benefit with toxicity. A combination treatment with Taxotere is more effective and should be used when the cancer is quickly progressing. It's important that people facing the use of Taxotere or chemotherapy be aware of clinical trials, and all things being equal, start your treatment early. And further, he's strongly suggesting that people now consider Zytiga rather than Taxotere. Zytiga was just approved in the US last year and is available in Canada. We know it as Warriors as abiraterone, and we have several Warriors that have tried abiraterone, some with success, some not with success. It's not been a durable treatment, but certainly there's been some effective reductions in PSA. So Taxotere has been the standard, but it's very likely that Jetvana will replace Taxotere. That's the country cousin to Taxotere, and that combinations will be eventually the name of the game, not monotherapy. So we'll move on to new treatments in the pipeline. So now we're really into research, and I hope you can stand techie terms and techie words as opposed to the technology on the hardware side. This is coming from Dr. Drake at Johns Hopkins. And interestingly, he's an immunologist as well, and is coupling a lot of picking up a lot of the thinking that Snuffy Myers is practicing, but doing it in his way at a intense research institution. So we have the drug MDV-3100. It's a next generation androgen receptor blocking agent. It's an agent that has three modes of action. It impairs androgen binding to the androgen receptor. It impairs the transport of that receptor into the nucleus, and it impairs the binding of the androgen receptor to the target genes. 3 shots in one. And that is really, I think, a powerful combination. It's in various levels of research trials. I'm personally in the PREVAIL trial, and I'm quite pleased to say that I'm on the drug and not on the placebo. If we look at ARN 509, it's got the same 3 modes of action, but the data is probably, at its point in its development cycle and approval, is probably 2 years behind the MDV-3100. Point is, there's 2 drugs coming on. There's going to be some competition both in terms of utility, effectiveness of the drug, and maybe price. Sipuleucel is the original name for Provenge. Provenge is the $92,000 US immunotherapy with a marginal benefit of about 4 months. Very costly drug program for a marginal advantage. So they're looking at combinations as well. And the combinations here are dealing with some added low-dose chemotherapy, as well as what he calls an immune checkpoint blocker. We'll just have to wait for the results on that. But again, the theme here is it's combinations of drugs, not a single drug. And certainly in the case of Provenge, they've got to get more effectiveness for the price of the drug in the first place. Here's something that I'll simply refer to as Cabo. And this is a drug that is working on, it works as a MET inhibitor, enough said. But it works on the bones, and these are stunning results on the bones. If you compare, and so far this has only been tested in a phase 1 trial with about 35 patients. This is before, and this is after. Notice how the bone scan cleans up. This is before, this is after. The bone scan cleaned up again. Before, after. They either use the word stunning or dramatic. The oncology community has not seen a drug that is as effective as this in terms of working on bone scans. And so we have evidence of bone scan resolution, partial or complete. Yes, yes, yes. Measurable tumor change in size, minus 41%. In this case, this went up 12%. In this case, there was no change. So there was some variation in the what was happening in terms of the primary prostate tumor. And bone pain, improvement, and no effect. So this drug is going to have a place if it can stand the rigors of phase 2 and phase 3 trialing. The point is, there will be phase 2 trials coming up somewhere. And for those of you that are in this particular situation of post-docetaxel, I'd be talking with your oncologist to see what's possible to get sponsored into a trial. So we have these drugs that are all coming down the pipeline. It's going to make life for the advanced patient more complicated, not less, because of the range and choice of options. It's going to make life much more complicated for the oncologists and for those that have to fund all this. So our conclusion is that there's lots of developments to look forward to. We think this is a really worthy conference to attend. The presentations are intense, they're focused, and they're relevant to people that are newly diagnosed, they're survivors, or the warriors. And if you want to read more, these are people from McMaster University, and they have published about emerging novel therapies. The date is 2011. And their conclusion is, and here it's nice to see in a scientific publication some reference to the Canadian context. I'll just read it. Lastly, in working under a publicly funded healthcare system in Canada, there will also be questions left to be answered by politicians and policymakers. The astronomical cost of the complete sipuleucel therapy compared to the more affordable cost of cabazitaxel, $5,000 per cycle versus $92,000, but you might end up with 5 to 8, 10 cycles, could surely influence what treatment modalities are made available in Canada to Canadians fighting metastatic cancer. So we've got a lot of new agents coming onto the scene for metastatic cancer. In the pre-docetaxel area, a lot of things that were not available 2-3 years ago. We only had docetaxel come onto the scene in 2004. And now we've got a lot of additional drugs coming on. Each of those could come into combination therapies with docetaxel. And in a post-docetaxel period, many additional drugs and many additional combinations. You're going to hear more about this, but I don't think it's going to get simpler. It just may get more complicated. But I gain a lot of confidence from this because I'm on a personal trail of medical oncology. I have not had radical prostatectomy. I have not had radiation therapy. I'm in one of these advanced drugs, as I said, with Medivation 3100. Seems to me that I'm on the drug and not the placebo. I'm a much happy camper than I was 4 months ago. Next year, September 7 to 9, 2012 in Los Angeles.